My name's Steve Yank. I'm a institutional capacity building specialist with HFG, and I'm very excited to see you all here. You know, I thought everybody was going to go to transition, but transitions comes and goes. No, transition's important, but I'm glad, we're really glad you're here. It's the institutional capacity building for resilient health system session, so hopefully you are here for that. And I just want to briefly introduce my colleagues who will be on the panel with me today in our conversation. First to my right is Fred Rosensweig. He is the capacity building advisor for HFG, as well as the country manager for DRC. Next is Desiree Boko, who is the chief of party in Haiti. And what's his name? Oh yeah, you met him this morning, huh? Damas, Butera, who is the chief of party in, why am I going blank, huh? Guinea. N'est-ce pas? Okay. Okay. So I just want to say a couple words, and then we'll have a conversation here, and then we'll have a conversation here. So institutional capacity building. Our experience is the default understanding of that is systems, processes, tools, training, end of story. We think it's a lot more than that, and we think that reduced focus on it is the reason why so often it doesn't work. So just to give you a sense of our understanding with this HFG project of what the different dimensions are, we got a handy-dandy handout on your table, if you want to just take a look at it. And you'll be hearing, I just want to walk through the dimensions on the left. There's a brief definition next to it. But you'll be hearing how these different dimensions are addressed as we have the stories of these three projects, the DRC, Guinea, and Haiti, in this session, okay? So as you see, we have the dimensions that we address in terms of our assessment and our interventions are the organizational mandate, okay, institutional arrangements, staffing, implementation capacity, systems and processes, nothing wrong with them, it's just not everything, resources, and then finally stakeholder, coordination, communication, stakeholder engagement. Okay, so those are all the way we look at this world of institutional capacity and institutional capacity building. Secondly, I just want to say that we have it's a systemic approach in, and you'll hear more about that, but systemic in first of all, the sense that there's a system here of different elements of organizations and of organizations working with each other, as well as different levels within the organization and all the organizations in the health system. Also, there's kind of three contexts that when we talk about institutional capacity building in HFG that we think about. One context is where it's a large-scale institutional capacity building effort. So the focus is on the institutional capacity building itself. And you'll hear when Fred's talking about the project in DRC, that's an example of that approach. Secondly, we often have projects where there's a very specific focused area of a health system that we're doing institutional capacity building on. And third, there's technical work that only is going to be successful if there's adequate institutional capacity to ensure that it gets done and is sustained during and after the project. And the examples from Haiti and Guinea will look at projects or programs that combine those two. Okay, so we'll have a chance to hear about all three different types of institutional capacity building. The title, Institutional Capacity Building for Resilient Health Systems. So what do we see as the connection? Well, if resilience is the ability of a system to withstand changes in its environment, okay, and especially rapid changes, and whether that's in the health field, changes in health and disease, changes in conflict and war, changes in environment and weather, et cetera, whatever they may be, our understanding and our thought about resilient health systems is that you need to have a certain level of capacity already to be delivering your services. But if you're resilient, you're able to raise that capacity so you can keep giving your services, providing those services, even when you're addressing the crisis or the change in the environment. Okay, so that's kind of our context. And again, why institutional capacity building is so important, because without that, you're not going to be able to make that really tough leap. And nothing against transition, but we really see that transition and institutional capacity building are very closely tied together, because if the institutions within the countries in which we're working are not strong enough as organizations and as systems of organizations, that transition's not going to happen. It's not going to stick. Sustainability will not occur. That's been our experience and observation. So just a word on our program. So we'll be talking for about the first 45. Well, I've already taken a few of those, but we're going to leave in 15 minutes then. If you could hold your questions, we'll have 15 minutes for question and answer at the end. And of course, there's a break then. You can come and speak with any of us afterwards. Okay? All right. So what I'd like to do is start with having each of my colleagues talk a little bit to give you an overview of the context of their country program. And then I have 5 or so specific questions. So maybe if we could start with you, Damas. Can you give us an overview of the program in Guinea?
Thank you, Steve. I think to the risk of being repetitive, you know the context I presented in the morning, but the institutional capacity building work in Guinea is to be situated again in the post-Ebola recovery strategy of the government of Guinea. The Ebola really highlighted the failure of the system. The system was collapsing. And if the system collapsed, it means there was a weak institutional capacity to address the issue. And the USAID mission requested that HFG support institutional capacity and even governance to make the system more transparent and effective. So again, based on the collaboration with others, we came up with a certain number of institutional capacity building activities in order to make the various departments more functional. I think I will not enumerate all of them, but this went far from, started from doing really a comprehensive assessment of the whole system to see the gaps in terms of meeting the core functions of the ministry. I'm referring to the functional audit. That was our entry point in order to really assess the weaknesses, but also the strength that can be streamlined. Apart from the functional audit, I referred to the leadership and management activity, but we did also streamlining some specific directorates, including, you can't perform the health system without the required human resource capacity. And as we referred to it in the morning session, there was a weak capacity, HR capacity. So we helped really to streamline the HRH function within the ministry. This goes together again. It is the case again for the IGS I referred to. But as I said in the morning again, Ebola was defeated because of a collaboration, partnership of various ministries. So we worked alongside improving, strengthening the coordination of the Ministry of Health. So to give you a background, as I said, HFG is a 2-year program. We had a total funding of 6 million, including 5 million from the health portfolio and 1 million from the democracy and governance funding. We had I think the office is run by a team of local staff, 8 technical advisors, but this staff, as you know, we had a lot of activities. They were complemented by many local consultants, regional consultants, and again, international consultants. We had to make sure it was part of the capacity building to bring in a local consultant and pair them with either regional consultants and international consultants. Much of our work really was done at central level, because in the spirit of, avoiding duplication of activities, there are other USAID-funded projects that were doing health system strengthening. So we ensured to liaise, and USAID asked us to concentrate on central level, really to streamline the ministry at central level, and the health directorate of Conakry. I think I didn't refer to this. Conakry accounts for 80% of the health workforce of the country. 80%. And if you look at Conakry, the capital, within the map of the country, it represents maybe even not 1%, maybe it's less than 1%. So that maldistribution. So many issues have to be addressed really at the central level. And the central is leading, so streamlining the central level. We did work at central level, but the way we organized our work, it had an impact at a subnational level. We liaised, as I said in the morning, whatever we were doing, we were associating other development partners working in the different regions for them to uptake those activities at a regional level. Thank you. I think I will stop there.
Great. Thanks, Damas. Desiree, tell us about the program in Haiti.
Okay. Good afternoon, everybody. Talking about the program context in Haiti, I will start by saying that Haiti is a very challenging country. It is one of the least developed countries in the Western Hemisphere, marked by natural disasters and epidemics. We all remember the earthquake in 2010, followed by cholera outbreak, Zika, and recently the Hurricane Matthew. Those I think continually threaten the already fragile health infrastructure. The HFG program is aligned with the mission strategy and to support the USG effort to strengthen the Ministry of Health leadership and oversight of the health sector. Because there was a weak governance due to specific issues such as a lack of an appropriate legal framework, also an organizational structure that does not allow the Minister of Health to perform core function, and also quantitative and qualitative deficiency in human and material resources. So HFG program aims was focused on three main areas: the human resource management, the health financing, and management and coordination. The objective was to strengthen the Ministry of Health through several technical streams of work in human resource and health financing, and in institutional capacity building, reason for what we're here. To improve the management and the coordination of the Ministry of Health key directorate to perform core function. So the program was implemented over 6 years by, let's say, through a local office. But I would like to take this opportunity to thank the Home Office. We have a supportive, how can I say, helper with the Home Office. And the office is composed of 20 people, passionate professionals, And we supported the 7 directorate of the Ministry of Health at central level, and the total budget was $21.7 million. So this is, in few words, the program context in Haiti.
Thank you, Desiree. And Fred, what can you tell us about the context for DRC's program?
Well, as you mentioned in the beginning, the DRC focuses entirely on institutional capacity building in the context of a decentralization reform that's going on in the country. That includes a restructuring of the central ministry from 13 central directorates to 8, and 52 disease programs that get folded into those 8 that operate vertically, separately, and expanding the number of provinces from 11 to 26. In that context, there is a lot of support and interest from the Ministry of Health. We started our project right after the mission issued its country development strategy statement, which they say is captured in 3 words: institutional capacity building. That they basically say, we've been working around central government for the last 30 years because it's weak. We can't do that anymore, not if we want to have sustainability. We have to bite that bullet, take a 20-year time frame, and go after it, and hold ourselves accountable, realizing you're not going to solve this problem in 3 to 5 years. But if we don't bite into that hard problem, we're never going to solve it, and we'll be here 20 years from now having the same conversation. We came along the very first project to be designed after the issue strategy. There's a lot of interest in what we had to say. But the mandate was quite clear. So from a consultant point of view, it's heaven, manna from heaven when you have your client who wants what you do. Our focus had to be narrow because way too big of a problem to solve with a $9.3 million, what ended up to be 3.5-year program. They asked us to focus on 2 of the 8 central directorates to make them functional in the context of decentralization, and 2 provinces, both in Katanga, next to each other. 2 of the 9 that AID focuses on. Just to give you a little bit of context, the Human Resources Directorate, which was one of the directorates, has about 85 people. On any given day, 30-some-odd people show up for work. No one knows where the others are. They get paid anyway, maybe. Whether you show up or not has no bearing on what you get paid. They're overcrowded in offices. They have no IT equipment. They don't have a direction. They don't have a plan. Donors that want to work on human resources come in and ask them to do things, help develop human resource development strategy. But really, when you think about it, how would you expect them to implement that strategy when fundamentally they're not a functioning office? It just doesn't make sense when you really stop and think about it, to work on a specific issue when the underlying context is that weak. The provinces the provincial administrations hadn't been formed yet. One of our 2 provinces, when we started, there's no one to work with. The people hadn't been named into the positions. Took 1 year before they named enough people that we could work with. Took a year off our calendar. So essentially working with a startup organization. This was our context and how we started. In a country that's weak to begin with in the best of times. What happened, so our 2 directorates, 2 central directorates, 2 provinces. We also had a very specific separate activity strengthening the financial management capacity of the Kinshasa School of Public Health so that they could receive funds qualify to receive funds directly from USAID instead of through intermediaries. And then as this really took hold in the last year and a half of the project, the ministry and the mission started to ask us to do more things targeted in other provinces. So we did some targeted work in 4 other parts of the ministry and the Faculty of Medicine. One of the things that most interesting about this is that in the course of 3.5 years, we had 3 external technical assistance visits entirely done locally, which I didn't think in the beginning was possible, but I proved myself entirely wrong. And the targeted visits were very specific to something. It was all done locally with home office support in various areas, which for a panelist making is an accomplishment that I think is really pretty noteworthy.
Thanks. So Fred, I know from our work together over the years, one of the things that we pay a lot of attention to is the demand for institutional capacity building, how critical that is. So can you talk a little bit more about demands?
I sort of set stage for that in what I just said. The demand was there from the mission. I can't underemphasize what it means when you're doing this kind of work, when the mission and the results they're holding you accountable for is institutional capacity building results in nature and not health results, which ultimately is what you want, but there's an intermediate step, or several intermediate steps. Mission understood that, which made for a great client, and held us responsible for giving definition to that and being specific about it. I can talk more about that when we get it, when we go on and ask some more questions. The ministry at the higher levels, up to the Secretary General, the senior central directors of the ministry, lots of demand, lots of interest. I can't say as you get down to the staff level that they even knew what we were there to do. If you have folks who've never been to any kind of management training, never worked in an organization where management was discussed explicitly, and you have a framework to talk about it, it's like if you've only been taught in a didactic method, that's all you know. So I can't say that the staff level, but they were open to engaging with us. I think we built the demand at the staff level over time, so that afterwards we couldn't deal with all staff in every intervention. It's too many people, didn't have enough money. The kind of feedback that we got is, at the end is, I'm not happy I wasn't included in X and X event. I'm sorry they weren't, but that's a nice problem to solve. That's an indicator to me of the demand that they were able to generate. So because of the context of the DRC, the demand was there from the beginning, and we didn't have to earn it, certainly at the decision-maker level or the mission level.
And how about, Damas, how about in Guinea? What was the situation with demand there?
Thank you. I think similar to what Fred has just said about DRC. In Guinea, even the nature of the project itself, the way it was designed by USAID is to provide institutional capacity building to the ministry. So the demand was there on the part of the mission. And I remember that during the scoping mission again, this was reiterated by the leadership of the ministry, by the minister himself. And we were lucky that the demand did not limit to the higher level of authorities, but even the technical departments. Like I remember the planning directorate called their Bureau de Stratégie et Développement. The deputy director, one of our meetings, said, we know that you are coming to support us, but please don't do the work on our behalf, but teach us how to do the work. And in French, it says better, they say faire le travail. It means really, don't feed us with the fish, but teach us how to. So you can see that the demand, and I think that is, that could explain a bit in quote the success of the project, and that we were able to do what we were supposed to do in such a very limited time of time. The demand were coming from the various departments, and the people were eager really to, the demand was there, I can say, Steve.
Okay.
Yeah.
So a little more on Guinea, Damas. So you had, principally you had technical objectives. How are you being intentional about including the institutional capacity building in the work you were doing, and what was the benefit of that intentionality?
I think, as Fred rightly said, that there should be really an explicit demand for the ICB. Otherwise, you will continue running the trainings, and after the trainings, things will not really change per se. So what we did really, we made sure at the beginning to encourage the various departments that we were supporting to kind of doing a participatory self-assessment at the beginning in order to rate themselves and to identify the gaps by themselves. And building from that to facilitate the process where they design the kind of activities that can address the weaknesses. And meanwhile, even though the project was short, we ensured really to maintain a close check-in with the client to see how things are moving and to get their feedback in order, if needs be, to address the support, to change the support we were providing. So that close contact with the client, but also the participatory, implementation with the beneficiary, I think made it to become explicit.
Okay.
Yeah.
And in Haiti, Desiree, how were you being intentional about the institutional capacity building, supporting your technical objectives?
Let's say that in Haiti, HFG had 7 technical streams of work in human resource and health financing, including the capacity building to manage health workforce, development of a performance management system, resources tracking, costing, hospital costing, business planning, also a reconnaissance and accreditation program, etc. So all these technical streams of work require an institutional capacity building to be sustained when the HFG assistance is over, as you said at the beginning. So to give you a better idea of what we did, let's go through one of the basic examples of our achievement, which is the reconnaissance program. So what was the background? In Haiti, we had about 400 private nursing training institutions. So the Ministry of Health raised a critical issue about the quality of the education of these training institutions, who provided low quality of education. So HFG has been asked to support the Ministry of Health through the Directorate of Training in Health Sciences, called DFPSS in French, to set up this program, accreditation process. So the objective was to ensure that these private nursing training institutions offer adequate and a high quality of education. At the beginning, when the work started, we assisted the DFPSS to make explicit this need, the necessary work in terms of institutional capacity building for this accreditation program. So we carried out an organizational assessment, identify gaps, as Damas was saying, and developed and implemented an intervention plan, including an appropriate structure in terms of mandate, in terms of attribution, values, etc., in terms of allocation of the staff. That resulted in the creation, to be more specific, of a unit with an appropriate or an adequate staffing dedicated to the accreditation program. Also, we supported with other capacity building work in terms of elaboration of evaluation processes and tools, which include video tutorials for the evaluators and the members of jury, manuals, etc., and training. So, as you see at the beginning, institutional capacity building includes several things in terms of systems, processes, tools, etc., training. So this is what we did. As a benefit, I think that the ICB work helped us to move forward successfully with the implementation of the accreditation program. Now, DFPSS leads entirely on their own this accreditation program. They have a potential to replicate this program with another training institution for other categories like medical doctors, midwives, biotechnologists, etc. And they are preparing to work on another very important aspect of accreditation, which is the creation of healthcare professional regulatory bodies. So this is, I think I have to stop there.
Yes, thanks, Desiree. Another question has to do with systems. So to what extent did you take a systems approach, Damas, in your work in Guinea?
I think I said it again in the morning. I think from the beginning we had to really adopt a systems approach, and many of our activities, supported activities, had that perspective. Borrowing from the work being done in Haiti, strengthening the human resource directorate. As you know, the health workforce issues are multi-sectoral. I think they go beyond, well beyond the Ministry of Health. In order to address the education issues, the ministry has to work with the Ministry of Education. In order to address the issue of salary, motivation, and this, they have really to work with the civil service, the labor. So that even the other professional bodies, that was a missing link in Guinea by then, because there was no multi-sectoral inter-ministerial committee really to look into the issues and to find in a consultative way the appropriate solutions. We helped them to set up the inter-ministerial committee, and but before that we had to do a SWOT analysis, and based on that we did a report that informed the ministry, the minister, to take a decree to establish the interministerial, intersectoral committee to address the HRH issues. And one of the benefits of this committee, I think it facilitated. Guinea is one of the few countries in West Africa that had no directorate, a full-fledged directorate of human resources. It had a division. It was at the level of division. And this division was only doing, the administrative staff. It means hiring and, posting and so forth. But the core functions of human resources. We are referring to the planning of the health workforce over many years. That aspect was not addressed too. The issue of education, training, being it in service or pre-service, there was not the correspondent to address these issues and to be the counterparts of the Ministry of Education. So this intersectoral committee helped really, and with our support, to erect the division to the level of a directorate so that the core functions related to planning, education, training, and management beyond the simple, administration of workers be addressed. I think that was only one of the work promoting the HRH to have that systems approach to address the health workforce issues. It goes again, I referred to the coordination mechanism. That also we did support the work, and as a result of the situational analysis, and in order to have within the ministry there is what we call a technical secretariat to support the coordination mechanism of the Ministry of Health. That supreme coordination mechanism has within the committee there is 11 permanent secretaries of other sectoral ministries. So we really, apart from the situational analysis, based on the findings, we assisted them to come up with a development plan of that technical secretariat to become more functional. I think I will limit myself to those two examples, but we have at least more than 4 directorates where we adopted a systems approach.
Great, thanks. And Fred, in DRC, with that pretty complex situation you were in, how did you use a systems approach?
Decentralization is the ultimate systems activity because you're redefining how everything works. So there's sort of no way to avoid that. If you're redefining the roles of what the provinces are responsible for, you can't do that without thinking what the central level is responsible for and vice versa. And a big part of our work was getting people comfortable with the new set of functions under decentralization. That happened in a number of areas across the board. There's the redefining planning systems and HR systems and how financing works and how budgets are developed. It's comprehensive and complex in a big, large country that's a weak institutional setting. So we had no choice but to think about that quite a bit. I think about it in terms of DRC that the systems level happens in 2 ways. One is up and down the system, which is basically central level to the provincial level to the health zones, which is the equivalent of the districts in most countries, and how that works between those 3 levels. Because even though we work at the provincial level, what we're doing is developing capacity to in turn work with the health zone level. We didn't have the resources to work directly in health zone level, but indirectly, a lot of what we did in building capacity was to be able to work and function with the districts. The planning is a bottom-up process. It starts with the districts, gets consolidated into a provincial plan, gets fed up to national level. So we had a lot of contact with districts, but our intervention point was the provincial level. And then there's across ministry, as Damas was explaining in the case of HRH, other ministries that have to be involved. Let me just give one example. One of the things that we did that became like a bestseller was what's called in French référentiel des emplois, which is like job descriptions, but it's more than that. The way the system works in Francophone countries, you have an organizational framework, a cadre organique, which basically says, here's how this office is structured, here are the functions of each of the structures within that office, here are the positions, and here's what those positions entail. All those positions have to be at a certain grade level. Grade level has salary implications. criteria for recruitment, complicated. You can't do this without involvement with the Civil Service Ministry. They have their own templates that they use. They have a set of procedures, and ultimately they have to approve them. So when we worked with our central directorates around this issue, we had them come to the workshop, be part of the delivery team, be the review, so they had ownership, and to make sure that what we did was consistent, because in the end, if it wasn't, they wouldn't sign off on it anyway. So that's an example of taking into account the systems, that specific interventions, but that happened in other areas. It also happens in the area of public financial management. This public financial management system is not set by the Ministry of Health, set by the Finance Ministry. So there's coordination across, depending on what the issue was, there's different ministry.
Thanks. So I'm wondering, as you guys think back over the projects or the programs, what did you find particularly effective in the institutional capacity building component? Desiree, you want to start?
About the approach.
Yeah, about the approach.
Let's say that I think that it is a standard. That is the approach. So we started by conducting an initial assessment using HFG, organizational capacity assessment, to establish the baseline. And the approach that we use for this initial assessment and the next step all focused on an inclusive and participatory process. I think that Damas has already talked about that. Through various meeting or workshop, grouping managers and their staff to validate the baseline, the finding of the assessment, to build consensus on the capacity building priorities, tools to be used, and also the intervention plan. Also validate the structure in terms of mandate, etc. has already thought about that, and establish or elaborate the job description for the staff. But what we did, I can say, which is very interesting and that I wanted to highlight, is that we decided to make some adjustments. So we coupled the ICB work with the evaluation, the performance evaluation system that were implemented in other directorate called CSEP, S-Y-S-E-P, in French, Système d'évaluation de la performance. CSEP is a mandatory performance management review for personnel in the public sector based on job description and individual performance indicators. So as I was saying, that it was very interesting because it was Wi-Fi that helped us save time, that helped us to make sure that managers and thank you, managers and their staff have a global vision of their structure, their job description, and how each can contribute to achieve the plan objective. Also, that help to better understand the sense of ownership, accountability, and also the team building. So I think that at this time I will stop here. Thank you.
Okay, thanks. How about in DRC, Fred? What about your approach?
Let me frame, I have three things that I want to mention specifically, but I want to frame it first. And in the context of our competing session on transition, we're working in 2 of 26 provinces. How do we leverage what we do in those 2 that can affect the other 24? I was aware of that from the beginning. And 2 of the central directorates, realizing that we only had the resources to work in a limited number, but we wanted to make sure that we did this in a way that would increase the chances it could be replicated in the others. So with that in mind, there were 3 things I want to point out I found that were particularly effective. The first reflects my own natural bias and view of the world. I work for Training Resources Group, an organizational development training company, so no one will be surprised at what I'm going to say. Full disclosure. But we really frame this in organizational development terms from the beginning. And what does that mean? To be clear, looking comprehensively at the organization in terms of what it's able to do and certain building blocks. They need a mission, a vision, a strategy, a structure that makes sense, a clear definition of roles and responsibilities, the ability to work in teams, the ability to manage themselves internally, to make adjustments and to learn from it. Quick summary, the longer definition, but you need to have all those skills if you want to be an organization. And you need to do it in a way that's highly participatory and engaging. It's not top-down with the client. And you need a range of interventions that accomplishes those things. We took that approach. Now, I knew when we were designing this in the beginning, the only way this works is if I can find these kinds of people in country. And we found ultimately 5 of them who really are quite good by any standard. And that's why we're able to get this done without any international assistance. Watching the understanding of what it takes to build an organization was a joy for me. And watching a level of understanding of how organizational development is really at the core of what we're talking about, institutional capacity building, was explicit from the beginning, and I think one of the interventions that really work. And obviously there's specifics to that. The second thing that we did, a lot of what we did, particularly at the provincial level, required the use of ministry-wide systems and processes like financial management, like supervision, like management of primary health care, like the planning process, the reporting process. These are things that we as a project could come up with our own system. So it's not that the ministry hasn't thought about these things, but we said we're going to use the ministry staff that help develop these within the ministry to go to the provinces and do that. We'll help design any kind of workshop or whatever you might do, prepare you. We'll pay the per diem and travel. There's no money in DRC for that otherwise. That's just the way it works. But we're going to use your staff to do this. And we did that systematically, and they were quite good. And everything that was transmitted, conveyed, the substance of what the provinces needed to learn, were Ministry of Health staff that were doing it. Those people are left behind, and they have set of materials, approaches. And it wasn't all training by any means. Some of it was the French word, which doesn't have a good translation of accompagnement. It's kind of follow-up. Those of you know French, accompany you afterward, not just do initial. I mean, that was a big part of it. So that was one. And the third thing I'd like to mention is that we talked about this a little bit in the morning session, but about really explicitly working through Ministry of Health processes and procedures. Those of you who've worked in DRC, it's a very protocolistic country. Mm-hmm. It's very formal, approvals and how things get done. If you're going to travel, you have to submit it terms of reference, get it approved, signed back by the ministry, and then you can travel. Or you can't just show up in a province if you haven't gone through essential stuff. Everything has a way of doing things. If you want a formal document, there's a process for reviewing it and validating it and approving it. We just followed those completely. We made sure that what we were doing were aligned with Ministry of Health priorities in the first place, particularly on those processes and systems that absolutely depended on ministry systems. And where they gave us a little more space with some of the organizational development, team building, leadership and management training, which we did, training in how to be a coach so that provincial staff know how to work in a more collaborative manner with the health zone staffs. supposed to come in and say, you did this wrong, did this wrong, did this wrong. How do you develop people as part of the coaching process? They gave us a lot of space when it came to those kind of interventions, because that wasn't in their wheelhouse, really, of what they did. But on all the stuff that required systems, we really went through them systematically. So I think the ownership is there. It's a critical element of passing this on.
Thanks, Fred. Time for questions, finally, right? Yay! We've got a couple microphones because we're recording all this. To my microphone people, so I see a question back here. There's a microphone. If you could just start off with your name and your organization, and then really succinct question.
Thank you very
Go
much.
for it.
My name is Sadia Parveen. I work for Save the Children, and I'm delighted to be listening in on this session. This has been really engaging, so thank you all. Now, going back to the title of the session and also linking it to the way forward, how would you think, or have, in your experience, have you had a chance to define resilience in the context of health systems? Number one. And the second part of my question is, have you seen that happen, or how do you see that happen in the different country contexts that you work in? Because at the end of the day, we're trying to build institutions that are not only sustainable but resilient, right? That is my understanding. And resilient not only to threats related to emergent disease or earthquakes, natural disasters, but all kinds of change, political upheaval, anything. So I had a two-pronged question. Thank you.
Yes, I noticed. Good question. Who'd like to? Fred?
Damas.
Oh, Damas? Okay.
Guinea's the ultimate resilient country.
Yeah, this is a very good question. You know, this is a debate, health systems strengthening and resilience. But ultimately, whatever we are doing currently and the interventions we have been supporting contribute not only to the strengthening of the system, but to make the system also resilient. By definition of resilience, as Steve said it when introducing, is the capacity of the health system to withstand shocks, either natural and if you take those, I know scholars came up with some specific measures. The system has to be aware. The system has to be adaptive, self-regulating, diverse. So take the example of Guinea. What we have been doing to make the system aware, we have been supporting the first activity we did contributed to make the system aware, to know the weaknesses, to know the challenges. We supported human resources for health. How do you call it? IHRIS. That is
IHRIS.
Yeah, we supported to streamline the human resources information, the work done by IntraHealth before. So all this is contributing to make the system resilient, for it to be aware of the challenges, to know the numbers of health workforce, their distribution, where they can tap into. All this is making the system resilient. The second characteristic of a resilient system, I think it has to be diverse, isn't it? To ensure that it provides not only the basic service, primary, and the whole continuum of healthcare. I think we contributed to this. We had a very strong component of HRH. We supported, like in Haiti, to streamline the quality of education. As they said, they had 400 schools, nursing and midwifery schools. The standard must be an issue. The same in Guinea. We have only one public nursing and midwifery school, but against 30 private nursing and midwifery schools. The issue of quality education matters. And really, even at a tertiary level, we need to streamline. We are helping them. There is a major reform in Guinea to adopt the LMD system. So we are keying into the process to ensure that this is done by streamlining the leadership and management capacity of the managers in order really to do these reforms accordingly. So I will not go by any. I know it's a debate, health system strengthening and resilience, but ultimately I think they are converging at one point.
Thanks.
That's my take on that.
Thanks, Damas.
Yeah.
Next question.
Hi, Heather Ross, IntraHealth International, and thank you very much for the mention. Early on in this session, it was mentioned sort of in passing the inherent difficulty of capacity building, which is that we're on 20-year trajectories building institutions in 5-year project timeframes. I know how we can talk, there was a question earlier, how we can talk to build demand for that sort of incremental movement within the countries. How do we show that demand to the people who fund the supply?
It's a great question. I have a simple answer. No, part of this, I think, I've been doing this for a long time. I've had countless conversations with the mission about the value of institutional capacity building in the context of timeframes for development projects, and particularly in a results-based environment where we're required. It depends on who you work with within the missions, is what I find. It's not uniform. We don't have this problem in DRC. I saw how it happened. It was the mission director, who I know from 20 years ago, and said, I know this is what it takes. She brought along her whole mission. And everyone was singing from the same playbook by the time they finished the CDSS process. That's the country development strategy. And now they all got religion. But it took some leadership at the mission level to say, we have to get beyond this. We have to ask for different things. One of the things she did to support that was develop a mission-wide capacity building measurement index required by all projects in all sectors. He really had a vision for what you want the mission to get. She left, continued like clockwork by her successor. It's so embedded now, I don't think it's going to change. I think that this is a larger question, and if the agency is serious about transition and the institutional part of it, they have to come to grips with the answer to your question. All we can say is, what are the results we'll get at the end of the 5-year time frame which exists? How does that create the stage for the next piece, and have that be designed in such a way that even if you stopped, it would be beneficial, even if incomplete. So I think we have to reframe how we define what we're about. And I do think it depends on who we're talking to with that. There's no simple answer for that. But for me, that's part of the answer.
Thanks. We have a question. And
Yes.
then another.
I'm Dominique Frere. I work for Dominique Frere Consulting. So I had a question about resiliency and potentially sort of some of the tools that you would recommend, or the good practice in terms of building resiliency. And I'd love to hear some examples about the use of digital health, which I haven't heard much so far. But some of the good practice that seems to be coming out would be, and it ties in very well with your 7th dimension about coordination, communication, and stakeholder engagement, which seems to be kind of one of the cross-cutting dimensions of all 7 of yours. So how can you use the sort of the use of digital? Maybe it's through social media, the storing and sharing of information, which all seems so crucial, particularly in fragile states where, you know, you may set up a committee and have wonderful policies and minutes, et cetera, and then it all changes with a new political or a national disaster and everything is lost. And so you really do have to have a way of passing on that knowledge and ensuring that there's not a continual sort of brain drain.
Okay. What about it? Any digital experience in Guinea?
Well, there are how can I put it? I think in the morning I referred to improving the strategic communication at the Ministry of Health level. This is a good direction towards, because there are tools. And let me talk about the Guinean experience. Actually, we got a request. This also referred to being adaptive and respond sometimes to the request of the ministry. We had we were lucky to have a very informant minister in terms of digital, and he put a requested with the project. We didn't have that in the project, but we thought it went with our communication support, and we supported the embedding of an advisor to look into the new technology. They call it in French the NTIC. Even in English, I think it's new technology, information, and communication. So it's coming up, and the idea is to do first the situational assessment of all tools that exist in the country, and try really to streamline them and to promote the new technologies coming, so that they can be the digital or medical learning and so forth. So there is a unit that has been created, and HFG has been part of it, because the technical assistant working on this, I think he has been funded by USAID through HFG.
Thanks, Damas.
Yeah.
We have time for one more question and one quick answer.
Yeah.
Quick question, quick answer.
I'm Timberg, really following on from your question about greater than project length. What attempts have you made to connect with institutions and initiatives that have a much more, a longer time perspective? I know about Haiti, they had some other projects working on the health statistics system. The other one that occurs to me is actually other donors and aid who do have a longer term perspective and will often commit or will cooperate with you on a study about the effects of 10 years leading up to the end of your project. Anyway, to what extent is there a possibility of linking with longer term perspective initiatives?
Let me come back to that. I often think of more things to say in response to a question and give it in a minute. We had an activity that I managed that ended in Burundi, which was very much like the kind of organization I described with DRH, the Human Resources Directorate in DRC, the HIV/AIDS Office in the Ministry. Moribund, ineffective, unhappy, 38 unhappy people. 2.5 years later, they were selected as the Global Fund public sector principal recipient for HIV. Not by us, but by their standards. That was doable in 2.5 to 3 years. When I was talking about a longer term frame, it's in a much larger institutional context, the Ministry of Health in general. It goes back to your question. I think it depends on what we're talking about, what that length of time is. I don't think there's a simple, everything takes 20 years. It doesn't. But if you want to grab the institutional context in a larger sense, the Ministry of Health, the health sector, and the institutions, that's a longer term perspective. If you take a specific issue like the health information system or something, that has its own set of time frame based on where the country's at. What I'm saying, you have to give it the time that it needs. But what that means depends on the issue and the situation and the country that you're in. I think it's a more nuanced response.
Have a quick,
Just to add that this is in an ideal situation. because in a fragile state like Haiti, sometimes institutional capacity building work need basic support, financial support to basic activity to allow the staff or the entities to apply what they could have learned from the ICB. So sometimes you start it and things are blocked because there are the difficulties to continue the process. So if you come back 20 years after, things are just what I wanted to add.
Thank you, Desiree. Well, we're going to have to end there, but you're welcome to come in and speak with the panelists. Thank you so much. Don't forget, there's a treat upstairs. They tell me it's parfaits. You don't want to leave now. And then we've got folks from the Gates Foundation, from USAID, from, I don't know, you don't want to miss it. So thanks for your attention. Thanks to the panel.